I want to introduce you to two rock stars. Dr. Mahima Gulati is a physician and associate professor at the University of Connecticut. And then Dr. Gebre Nida, he is a physician in clinical practice in Reedsville for Cone Health. Please welcome Dr. Gulati, who's going to speak first, and I turn it over to you.
Good afternoon to those who are on the East Coast, and good morning or good evening to the rest of our participants. It is truly my honor and my privilege to be here. Thank you so much to the extraordinary team at American College of Lifestyle Medicine, particularly Leslie, Paulina, and Andrea. Thank you for hosting this webinar. And I also want to thank Dr. Nida, who is my esteemed colleague and dear friend. And it's a joy to co-present this educational opportunity with him. Through this webinar today, we are trying to accomplish the following objectives. We want to discuss the ACLM's initiatives to combat type 2 diabetes, which, as you know, is a scourge, is the defining disease of the 21st century. We want to explore certain evidence-based tools and resources for healthcare professionals. And honestly, ACLM has produced some exceptional resources. We want to empower individuals with practical, implementable strategies for diabetes management, access to specialized courses designed to enhance knowledge and skills, and Dr. Nida is going to dwell extensively on those. And then we want to leave some time for Q&A. So with that, I don't know, Leslie or Andrea, if you can advance the slides. So I have no disclosures, but I do serve on the board of directors at the ACLM. Next one. I want to begin with my journey in lifestyle medicine. I think some of you all may have read this blog that that Alex Branch and I co-authored. I was like, I think thousands of professionals across our country in healthcare on the verge of burnout. I, am an immigrant physician, and I was practicing endocrinology as a senior attending for years. My day was long, my hours were long. I used to spend a lot of time on my computer typing and dictating and prior authorizing a lot of paperwork. But it seemed to me that all this hard work was mostly going in vain. And I don't think I was achieving the most efficacious outcomes for my patients. That was a very, I don't have the word to describe it, but it was a very defeating feeling, a disappointing feeling. I wanted to be better. I wanted to do, more for my patients. And that's when I came across the words lifestyle medicine. The path thereafter was, as Leslie mentioned, transformational for me. It was a complete sort of a transcendence. And I, had a new mission to bring lifestyle medicine to not just my patients, but my teams, my co-professionals, my colleagues, my, staff, including dietitians, behaviorists. And that was really a little bit of my journey. I used to work at Middlesex Health System until recently. I have basically converted to academia. Now I am on faculty at University of Connecticut. So, the next stop really is, more of a dialogue with fellows and trainees and residents and medical students, and really practicing lifestyle medicine till the end of my life. So that's a little bit of my journey. Next slide. I wanted to begin with some what I call, really, these are actual real statistics, but also very horrifying. And I think a lot of you all may have read this Lancet editorial from June 2023. This kind of coincided with the American Diabetes Association scientific sessions, their annual meeting. And Dr. Nida will talk more about this, diabetes, the defining disease of the 21st century, and how, I think this entire edition of Lancet focused on the inequities and the social determinants of health, and how, entire healthcare systems across the world, not just our country, have not fully grasped the social nature of diabetes. So next slide. Some of the statistics that I want to go through, next slide. An average 50-year-old patient with diabetes loses 6 years from his life expectancy compared with a counterpart who does not have diabetes. This is from the CDC data. Two things. One, this is a 50-year-old, so somebody who got diagnosed with diabetes, particularly type 2 diabetes at a much younger age. I actually work in an underserved community where regularly my patients with type 2 diabetes start in their teens or even in their childhood. Many of them have actually complicated type 2 diabetes by the time they turn 20. And many of them are on dialysis and have had end-stage kidney failure by the time they turn, late 20s or early 30s. So this statistic does not apply to people who got type 2 diabetes relatively early. The second thing about this statistic is this is perhaps American statistic. So if you go to the rest of the, the lower middle income countries in the world, their life expectancy loss from type 2 diabetes is much more monumental because they do not have advanced health care in terms of being able to manage somebody with diabetes with septic shock or foot infection and so on. So really terrifying statistic. Worldwide of, I'm sorry, please go ahead. Worldwide of all the deaths among diabetics, almost half, 48% occurred before the age of 70 years old in 2019. This is pre-pandemic, and this is data from the World Health Organization. Now, World Health Organization defines premature death as a person who passed away before the age of 70. And globally, almost half of type 2 diabetes patients will not make it to their 70th birthday, which again is a big, problem. Prevalence of diabetes has risen 5 times in 4 decades. Now we are basically more than 500 million people living with diabetes. 96% of that is type 2 diabetes. This is worldwide, more than 500 million already. So really, burgeoning, like soaring prevalence of type 2 diabetes compared with just a few decades ago. This is the data from that Lancet edition I was talking about from Global Burden of Disease. We will have a human population of 10 billion estimated by 2050. Out of these, more than 1 billion will have diabetes, majority type 2 diabetes. In terms of the global economy costs, we are spending nearly $1 trillion, 966 billion US dollars for adults. This is just for adults on diabetes-related health expenditures. Now, if you compare that to global expenditures or global economy share of all cancers combined, that's less than 900 billion. So as you can see, diabetes has monumental costs. More than 1 in 10 healthcare dollars across the world go to diabetes-related expenditure, according to the International Diabetes Federation calculations. So these are some really awakening or eye-opening statistics, in my humble opinion. Next slide. Some of us are visual learners and we like to look at pictures better than data and graphs and numbers. This was something that I found on social media, and look at our diabetes epidemic. We cannot imagine this picture in maybe my mother's or grandmother's generation, where diabetes care and weight management coexist alongside cosmetics or skincare. That is where we are. This is something that is part of daily life. And this was not the case just a generation ago. So again, eye-opening in my humble opinion. Next slide. I was telling you about my journey. How was I going to, I was a typical practitioner working for fee-for-service, RVU-based medicine in a health system. How was I going to implement lifestyle medicine, evidence-based lifestyle medicine in my usual practice? And what follows next is I'll try to give you some tools and resources on how to do that in your routine office practice. Next slide. So the first step for me was going to be to educate myself. That process started with getting myself board certified in lifestyle medicine, as Leslie mentioned in the previous slides. And one of the big reasons I thought to educate myself was to clear the noise and to really get to the evidence. Because if you go and, whether that's popular media or social media or any other channels, there is a lot of confusion and noise about what exactly would be evidence-based nutrition. And it was really paramount for me to understand, what does the data say? What does the literature say? And it was more common than dissimilar in terms of what the major studies indicate, and the common sense or the commonality in most of the studies came to what our colleagues at ACLM Research Department and our staff have published. This is a wonderful systematic review of guidelines, 78 guidelines by different stakeholders, different healthcare organizations and medical societies. 12 of these were concentrated on people with diabetes, pre-diabetes, including even type 1 diabetes in 8 of these guidelines. And it turned out there is the similar theme, the food groups that were recommended by majority of them, as you can see, 75% of the guidelines said increase the intake of vegetables. As you know, we are not eating adequate vegetables in our country, adults as well as kids. Increase fruit, just to harp on that, increase fruit was the guideline by almost 70% of these 12 stakeholders. So to really clarify the difference between complex carbohydrates or healthier carbohydrates versus obviously ultra-processed refined foods, etc. Increase whole grains, again, whole grains, whole intact grains, whether that comes from quinoa or intact barley grains or steel-cut oats, etc. Again, limit alcohol, 62% commonality among all the different 12 different guideline papers. Limit sodium or salt intake. So this was really an important step for me to educate myself, and I have really been privileged to be able to follow the literature over the years. Next slide. This is another excellent paper published by the ACLM team. This was the expert consensus statement published in 2022 in American Journal of Lifestyle Medicine. I was honored to be one of the co-authors of this statement. This is endorsed by the ACE, the American Association of Clinical Endocrinology, supported by the Academy of Nutrition and Dietetics, and co-sponsored by the Endocrine Society. And we had a lot of representatives from various organizations, including the American College of Cardiology, American Academy of Family Practitioners, etc. So there were 69 statements that the experts agreed upon, the consensus statements, and we followed a validated Delphi method. 3 of the key statements I want to enumerate in our webinar today. Type 2 diabetes remission, defined as an A1C of less than 6.5% for at least 3 months without any surgery or devices or active pharmacological therapy for the specific purpose of lowering blood glucose. And this is in concordance with the position statement by other organizations as well, including Endocrine Society, American Diabetes Association, Diabetes UK, etc. They define the remission of diabetes similarly. Diet is a primary intervention for type 2 diabetes and can achieve remission in many adults living with diabetes, type 2 diabetes. This document was related to type 2 diabetes remission. And it's related to the intensity of the intervention. About the intensity, there was exceeding like a preponderant agreement among all experts. So the intensity really is important. And I know Dr. Nida is going to delve intensively into the, the kind of intensity efforts we are lacking in practices and what we need to really focus on. Diet as a primary intervention for type 2 diabetes is most effective in achieving remission when emphasizing whole plant-based foods with minimal consumption of meat and other animal products, as well as ultra-processed foods such as sugar-sweetened beverages, etc. So next slide. This is a slide from Diabetes UK. These are actually available on their public domain. I have listed that domain here. I think many of our listeners on this call might be aware of the DIRECT trial. These are very popular studies that originated from the UK, and now they have published data from DIRECT Australia as well in 2023, October 2023 in Diabetes Care. So, this really was a game changer. They recruited clinical practices, primary care practices essentially. And this was a cluster randomized trial. So some of the practices did the direct intervention, which consisted of, the first 13 weeks were really intensive, very low energy diet. Then they followed that up with stepped food reintroduction, and then they maintained the weight loss or the dietary intervention for the remaining duration of the 2 years. And what they found, and there were certain practices which were the controls, which did not do that. They just followed the national guidelines, the UK NHS guidelines. And they found that almost half of the patients in the practices which were given the intervention, 46% of them went into remission by the first year, and more than 1 in 3 remained in remission by the second year. So 36% remained in remission. But more importantly, those patients who achieved a minimal of 10 kilograms of weight loss, which is 22 pounds, their chances of being in remission at 2 years was more than 60%. Now, this data is also available from Australia, but it's only for 1 year. They did not have control practices in this. They just had the intervention practices. And they found that those patients who were able to lose 10 kilograms of weight had a 75% chance of being in remission at 1 year. So these are really encouraging studies. And there are, different studies across the world. There is the Diadem study from Doha. There is, of course, Look Ahead from the US practices. And I think, I would encourage our listeners to go look them up if they've not already been familiar with these diabetes remission studies. Next slide. Again, a picture is worth 1,000 words. So this was just a subset of the patients who were enrolled in Direct UK. And they did MR, magnetic resonance spectroscopy imaging, looking at the morphology and anatomy of their pancreas. And patients with type 2 diabetes, they started with smaller volumes of pancreatic, because their beta cells are slightly dysfunctional, and they had irregular contours or borders. But when they underwent remission, their pancreatic morphology improved. It almost came up to normal within 2 years. The volume normalized and the contours became more regular. And this is, when I present this at different talks, the audience gasps at, the change in morphology and how it's really reverse aging in a way. Although I hate to use that terminology because that's not as scientific as I would like it to be, but really, the unwrinkling or the rejuvenation of the beta cells, to look at that radiologically is extremely impressive. Next slide. So it was clear to me, the data, educating myself, and it's a journey that, is ongoing and will be ongoing. I would love to keep on learning more and more about how lifestyle medicine brings about phenomenal outcomes. But a component of this was also research. I wanted to engage actively in research, publish practice-based research, publish my data, and I know Dr. Nida has done the exact same. We started with a pilot from our own small community outpatient practice. And we really harped on shared medical appointments, which I thought was the most bang for the buck in my RVU-based medicine model. And I know Dr. Nida will share some more reimbursement models or, ideas for health systems, how they can do lifestyle medicine and practice lifestyle medicine more practically and more sustainably. But I would encourage our practitioners who want to do lifestyle medicine to publish their practice-based research. Next slide. So we started shared medical. We actually launched the entire lifestyle medicine service line. We created a website, we created resources. Most of them were borrowed from American College of Lifestyle Medicine, but a lot of them came from, Loma Linda or VA or Paving Wellness, etc. And the shared medical appointments, these have been around, I think, since even before 1990s, really. There are multiple health systems across the country, whether that's Cleveland Clinic or MGH, that have done these extensively, published on their efficacy extensively. There is data from the VA. And we started our own shared medical appointment. We had a behaviorist. It was our certified diabetes educator slash registered dietitian. And patients really loved it. Next slide. I also wanted to bring in the impact of one of our very key lifestyle medicine pillars, which is social connection, and the opposite of that, which would be loneliness or isolation. This is an essay from the Wall Street Journal from February 2022. And this was one of the key factors in, my own practice transformation and why I was strongly able to argue for shared medical appointments. And I'll talk more about in the coming slides. Next slide. So, I was able to harness a lot of resources from the American College of Lifestyle Medicine, and these are available to most members, actually all members, and many other resources which are available sometimes even to non-members. But to be able to prescribe lifestyle medicine systematically, I kind of had to educate myself and my staff, my team members, on how to create smart prescriptions. These are specific, measurable, achievable, realistic, and time-sensitive goals that patients can co-create shared decision-making in the confines of either a 20-minute appointment or a more luxurious 90-minute appointment, shared medical appointment. And it became, as Dr. Nida will share, he does what he calls power encounters, but it became really standard practice for me to, do lifestyle medicine intake at each encounter and to have, not just pharmacotherapy or referrals, but also have a lifestyle medicine prescription at the end of each encounter, whether that patient saw me for type 2 diabetes or even for other endocrine disorders, be they thyroid disorders or PCOS or things of that nature. So next slide. This is, what we did in our shared medical appointments. This is a real picture from our, culinary demos at our shared medical appointments. This would be, as I said, loneliness or lack of social connections was a big driver for me and my staff, my team. So, we would gather patients and their caregivers around for, a culinary demo, and they would, I remember there would be patients who did not care for kale or had never tried, different varieties of squash. And our registered dietitian, she was able to create a small pantry. We actually had minimal funding from our health system. They supported us with a grant. But that we were able to make that argument because shared medical appointments typically would bring in more revenue than a standard 20-minute follow-up appointment. So, she created a pantry of like common spices, whether that would be cinnamon or black pepper and things of that nature. And we would have nominal funding for, buying a couple of things for produce each month. And it really was something that transformed patients. I do not think I have the time to dwell into the individual stories, but really, the foods transformed patients in their approach to how they can try things that they have not previously tried in their kitchens or in their plates. So next slide. This is the food frequency questionnaire that I used, but today actually we went live. We have a new diet screener. The American College of Lifestyle Medicine has published a paper in Frontiers of Nutrition. Our research department, created this with extensive inputs from other healthcare providers, and I cannot wait to use that diet screener. The press release, like I said, comes out today. It literally comes out today. But so far in my practice, I had used this food frequency questionnaire, which barely took patients 2 or 3 minutes to fill out. I can actually show you an example on the next slide. So this is a real patient from my practice. And like I said, every single patient who saw me would fill out this questionnaire. And it would take me literally a glance to see whether they are eating top heavy or bottom heavy. So the bottom are the foods which we don't want our patients to eat, whether that is fried foods or processed snack foods or sugar sweetened beverages. And as you can see, my patient here, they are eating 7 servings of processed meat every week. They're eating 10 servings of fried foods every week. whereas, they're not top heavy, so they're not eating much in the way of leafy greens or other vegetables or berries, not eating much in the way of legumes, right? So just a glance would tell me a little bit about a very important, vital part of someone's history if they have diabetes or any other endocrine disorder for that matter. It would give me an idea into their usual dietary intake on a daily or a weekly basis. And then, like I said, we now actually have a colored, beautiful pictorial representation of the same dietary screener, but with much more, I think it's going to be a little bit more efficacious because it gives examples. And again, it takes barely a couple minutes or so for patients to fill it out. And again, it would give the same type of idea to us as providers. How can we quickly assess what is it that our patients are eating? So next slide. This is the shared medical appointment toolkit, which I would like to share with our listeners if you all have not already checked it out. It really breaks down all the questions that you may have. How can you market a shared medical appointment? What do you need to tell your billing department? How do you bill for them? How do you publicize these? How do you set these up? What kind of infrastructure, what kind of space would you need if you want to do it virtually? What kind of coding, modifiers, etc. you would need? What other providers or professionals can join you in a shared medical appointment, etc. So extremely useful document. Next slide. And then, like I said, this is really a systems approach. Our health systems don't need to be lonely or alone in pursuing lifestyle medicine. And the American College of Lifestyle Medicine, under Tyler Hemmingson and Cassie Diestel and Martin Tell, we've created a beautiful health system council. We have 108 health systems already at this council. They meet at least once a quarter, and then there are monthly meetings for some of these discussions. And a lot of big health systems across the country are on this council, including the VA, Mayo Clinic, the New York City Health and Hospitals, Kaiser Permanente of certain regions in California, etc. So it's wonderful if you all are representing health systems that are not already part of this council. Please consider speaking with your administration if this would be something that you all can be part of. And this is a great community to exchange ideas. Really, catalyzing change and implementation, and how can we standardize lifestyle medicine practice and learn from leaders in the country. So next slide. I also wanted to highlight certain other publications from the ACLM, including this case series from a wellness clinic, a practice where we described, this is again, Michaela Carlson, Gunadhar Panigrahi, and the rest of the ACLM team. They published a case series of 59 patients. Average age was 71.5 years. And out of this, 22 patients were able to put their type 2 diabetes in remission with a low-fat, whole food, plant-based diet. Now, this was over a period of an average of 4 years. Most of these were basically type 2 diabetes, whether medication controlled or not on medication. And really, this was a nice demonstration of how free-living individuals in a community practice, with limitations in resources, can still benefit from this type of dietary and lifestyle medicine approach. Next slide. And then this was another research paper published by the ACLM team on deprescribing methods, which I think would be a concern for many of the listeners on this call. How do we deprescribe medications actively based on how intensively or modestly our patients are making lifestyle medicine changes. And the protocols, we went through different LM practitioners across the country and how do they systematically approach deprescribing, particularly type 2 diabetes medication. And next slide. This is the approach that most experts agreed upon, and I think we will be publishing more and more research on, including even clinical practice guidelines on how can we systematically deprescribe. So obviously, costliest medications first. If patients cannot afford them, then maybe they should be deleting those medications or de-escalating those medications first. And then, of course, insulin, because that is the one that is the most burdensome cost-wise and also in terms of adverse outcomes or hypoglycemia. Then, of course, sulfonylureas, again, very high risk for hypoglycemia if somebody is doing intensive lifestyle therapy. And then the next step would be TZDs, basically, which is pioglitazone because of its weight gain potential. Then DPP-4 inhibitors because of their limited efficacy in terms and no superior cardiovascular outcomes or benefits. And this has been the consistent approach of LM practitioners and experts across the country. And there's more and more data accruing on how this is really the right way to go about deprescribing type 2 diabetes medications. And then, of course, using continuous glucose monitors to really have a very granular idea of how our patients are doing as they are implementing lifestyle therapy, and how can we really use best practices and help them the best in terms of decreasing their medication intensity. And then this is my approach, but I think, again, really very consistent across experts across the country. After the DPP-4, maybe SGLT2 inhibitors provided, and only if they are not using it for any other indication, whether that is if they already have chronic kidney disease or nephropathy with proteinuria, etc., then maybe it's not a good idea to deprescribe the SGLT2 inhibitor and keep it on, even if their A1C is at goal. Then GLP-1 receptor agonists, again, provided they are not using it for a cardiovascular indication or any other FDA-approved indication that may get thrown off if we deprescribe, even if they're doing lifestyle approaches. And then metformin was the one that most experts agreed upon, that should be the last one to go, given the cost effectiveness and really, wealth of data in terms of how patients may benefit from keeping metformin on until the very end. So next slide. I wanted to, just in the interest of time, I'll go through this quickly because I know Dr. Nida has wonderful slides and resources to share. This is just a reverse ACE algorithm in terms of if somebody is implementing intensive lifestyle therapy, then, their insulin needs, they need to be adjusted accordingly, whether that would be if they are very high risk for hypoglycemia or already experiencing hypoglycemia, then they may need to go down by anywhere from 20 to 40%. But if they are not experiencing severe hypoglycemia, then maybe begin with 10 to 20%. And it would also depend on really how much their blood glucose is currently. If their blood glucose is, consistently above 200, then maybe they will not need that much decrease in their insulin dosing. And with that, I think I'll conclude my end of the presentation and let Dr. Nida take it from here.
Thank you, Mahima. Can you hear me? You can hear me, okay. Hello, everyone. Thank you for joining us this afternoon out of your busy schedule. I'd like to first thank Paulina, Andrea, Leslie, Tyler, SELM staff, all of you, SELM Health Systems Council, Dr. Gulati and Shannon for this opportunity. My name is Gebre Nida. I'm a consultant endocrinologist. In Cone Health, I am a board member for Anipen Hospital Foundation. I was born and raised in Ethiopia. My accent is from there or from different sources. English is my third language, so you may have to think a little bit to get it. And I work for, next slide, Cone Health in the Triad area of North Carolina. Based in the city of Greensboro, about 5 hospital system, about 14,000 employees, and 120 plus physician practices. Next slide. I have no conflicts of interest to disclose. I'll tell you my when, who, what, where, and how. Before April of 2022, I was just an everyday frustrated endocrinologist with my share of burnout and nursing, all of that. And then some of you may know already, but I'm a long distance runner. One day after my long run, I was doing a plank. And to distract me from that plank, a Medscape article in my email saying how to prescribe food as medicine by Kate Collins, the then president of ACLM, showed up. And I read it in 5 minutes, and so much enlightening information. And basically, this article introduced me to ACLM and lifestyle medicine in general. My outlook about medicine has transformed for the better that day. Although supposedly I was the expert in diabetes and metabolism, I admit to you that I was clueless before that day. On one hand, in my mind, I was doing a great job following guidelines. On the other hand, I was really burning out due to lack of progress in my patients' health outcomes. The journey I subsequently took to get board certified in lifestyle medicine transformed me as a person, as a physician, and as a citizen, and as more. Next slide. What I liked about lifestyle medicine and ACLM in general is the top 3 points, really. Health restoration, which have never been really emphasized before. Disease remission or reversal, again, another point. And medication de-escalation. I was really being conflicted by the amount of or number of prescriptions we give to patients with no plan whatsoever to deprescribe or to revisit the plan even. So those are very exciting and attractive things for me to stay in ACLM. The next points are kind of my own. Go back. Patient-centered multidisciplinary care is another attractive feature of lifestyle medicine. Shared medical decisions that we are able to make with our patients. The health span versus lifespan, meaning the amount of health you have in your life. And the health equity that everybody is talking about. However, finally, I found lifestyle medicine to be a great equalizer because it does not need the heavy machinery that we always worry about. No MRI, no CT scan, no heavy buildings. We can deliver lifestyle medicine in parking lot, in makeshift setup, and etc. So those are really attractive, unique to lifestyle medicine. Next. So I'm sure you know, some of you may know Dr. Paddy Barrett. He's really my go-to guy for when I try to explain something. And this is his cartoon showing us that we're going to die one way or another from cardiovascular disease, whether at age 70 or at age 100. A retained cholesterol molecule is what sparks heart disease again. However, what really puts that on fire is insulin resistance, because insulin resistance is just like pouring gasoline into that spark, and you know what happens next. So this is a continuum of insulin resistance from insulin sensitivity to type 2 diabetes at the other end. So we have a lot of opportunity to impact these patients' lives, be it on insulin resistant phase, metabolic syndrome phase, prediabetes phase, and all other metabolic syndrome manifestations. And next slide. The same guy posted this very huge study from Denmark, relatively recent. They were really trying to see the onset of cardiovascular disease as opposed as versus the time of onset of diabetes. They collected about 142,000 people with newly diagnosed diabetes and compared them with almost 400,000 sex and age matched individuals from the general population. And you see that diabetes pulls forward the onset of cardiovascular disease by 10 to 12 years. This is a huge opportunity for us to impact or lower the burden of disease and prolong life for our patients. Next slide. And Mahima went over this Lancet editorial nicely, but I have some kind of take-home messages on the next slide. This Lancet, I hope you read it. If you did not, there's a chance to read it. It's a free article. It shows that 75% of the next burden of diabetes will be in middle and low-income countries, and projected to be 1.3 billion in 2050. And the highest burden and worst clinical outcomes are, as you know, in the racial minorities. And there are a bunch of reasons: structural racism, geographical inequity, which amplify and compound the social determinants of health and affect the care and treatment we give. A much broader, ambitious programs are required to address this. Unfortunately, the focus so far has been heavy on biomedical and device interventions instead of addressing the root cause of the disease. In that article, you will encounter very exquisitely smart authors. I'm not here to sell people, but you will see a book recommended in there. Topic is Inflamed by a couple of authors. The subtitle is Deep Medicine and the Anatomy of Injustice. I highly recommend that book to you. I read it and I learned a lot. The world has failed to understand the social nature of diabetes and underestimate the true scale and threat the disease poses. This is personal. Again, we are basically too late to prevent only. When it comes to type 2 diabetes, we should start and we should have started reversing chronic disease, including diabetes. And it's not, there is no time to waste. Next slide. One of the things that you will appreciate in SELM is this Proclamation and Diabetes Bill of Rights, nicely summarizing the burden, the pathology, and the the kinds of diabetes on the proclamation. And SELM basically informs our patients that they have the right to fully informed about treatment options. They have the right to know about what certain foods may help them reverse it, treat it nicely, or even delay complications. And they have the right to work with their doctors and healthcare professionals to understand the link between diabetes medications and complications and side effects and all that. And I highly recommend that you download it, read it in entirety. Next slide. The good news is that major organizations are actually catching on. I was really encouraged to see these ADA publications titled Type 2 Diabetes Remission, a new mission in diabetes care. So what I liked, the summary saying that after they summarized all the studies done to, on a small scale to reverse diabetes, the final statement was, it is time to embrace type 2 diabetes remission as a key therapeutic goal in type 2 diabetes and offer intensive lifestyle intervention to increasing number of people with type 2 diabetes. Because type 2 diabetes remission does not occur spontaneously. It's less than 1.5% from what I saw for it even to happen. But again, there is a huge opportunity considering millions of, or now 500 million of people with type 2 diabetes, a significant number. Next slide. So context for this presentation, for this webinar, and for the course that you will be undertaking, hopefully, to reverse diabetes. Here are the 4 points. The current standard of care for diabetes do not aim for or result in type 2 diabetes remission. Intensive lifestyle medicine intervention is required, ITLC, is required for successful type 2 diabetes remission. There are a few proven effective interventions. Mahima already mentioned some of them are available for type 2 diabetes remission. There is unfortunately no current reimbursement scheme for type 2 diabetes remission. The kind like we know in intensive cardiac rehab for coronary artery disease, CHF. However, there are efforts underway to bring those contexts back to clinical practice, as you will discover on subsequent slides. Next. So when you are developing LM programs tailored to type 2 diabetes remission, there are certain things we have to fight for. It has to be evidence-based. It has to be proven interventions backed by randomized controlled trials. It has to be measured by rigorous outcome data over multiple years, at least 2 years, and reimbursement for ITLC has to be sought. Since there won't be any procedures or surgical practices in this endeavor, reimbursement should be hourly based, just like ICR. And the certification should be sought through recognized authoritative entities like CMS. And one of the speakers in the course is John Kelly. I'm going to mention him a couple of times, but there are other very distinguished speakers in the course. Next. The current format of existing type 2 diabetes remission programs are at best very small in scale. For example, Mahima mentioned the counterweight program in the UK, aiming for a very low energy meal to bring about 30 pounds of weight loss, about 10 to 15 kilograms. They show that there is a 46% success rate at 1 year. Again, this was not practiced elsewhere, still in UK primary cares. That's a very good standard landmark study for us to learn from. PVO, which formerly CHIP, is a private program. It doesn't have randomized controlled trials. However, it has shown in smaller scale it can be effective for reversing diabetes. The look ahead, the diadem programs that Mahima mentioned are varying success rates. The diadem has a 61% success rate because the patients studied were at least a decade younger than the other studies that we looked at, for example, at Look Ahead. There are other web-based commercial programs, Diabetes Undone, Mastering Diabetes, WellStart, and the Verta programs also have small but scalable, however, becoming very popular programs for the commercial interest in the web. Next slide. If you want to achieve a very good document for diabetes remission, then we have to be very careful in tracking our outcomes for all patients. So far, the tracking has been heavy on hemoglobin A1C and diabetes medications. However, even the major guidelines or societies did not require insulin resistance by HOMA-IR. However, if you have it, if you have the facility and the capability, it's recommended. What they also recommend to measure include related comorbidities, for example, heart disease, hypertension, hyperlipidemia, the biometrics, other medications, other lifestyle practices, for example, sleep, stress, exercise behaviors of the patient, quality of life. Validated tools should be used to measure it, and the long-term outcomes. And for example, if you have a very brief 12-week or 16-week type 2 diabetes remission program, you have to have a way of capturing some of those patients, either by a drop-in or by some kind of follow-up to assess how they are doing after they detach from the program, usually followed by PCPs and other providers. Next slide. And then you will meet these distinguished speakers in the course in the type 2 diabetes remission. Next slide. There are several topics. Again, I'm not going to go into detail of this. These are the things that I thought I mastered them as an endocrinologist. However, I learned a whole lot going through this course, and I'm sure most of you will appreciate and enjoy the high level, high impact nature of these contents. Next slide. And there are other resources, even if you don't pursue certification or get the membership, you will appreciate the resources listed here for your clinical practices. Next slide. So how I did it was that one weekend on July 2023, I rented a hotel room and I sent my family to a beach getaway. They didn't know what I was planning, but I used that weekend for a power study, went over the 18 modules and got certified. Of course, it took a lot of coffee, a lot of chickpeas for a snack, and this is one of the most rewarding certificates I was able to collect, and I hope you follow the same path. Next slide. So the lifestyle medicine journey for me has been very rewarding. However, you have to know that this journey improves lives. Next slide. Makes financial sense. It requires time and commitment. It is shared. It must be aligned. It is communal. It demands creativity. It's digital, and it's nuanced. Even your best friends, close colleagues will bother you sometimes. They question your sanity, but at the end of the day, you will see it on your patients' faces. This is really the right thing to do. Next slide. So I'm working with my Cohen Health, my system, to start a lifestyle medicine practice down the road. However, I could not wait to kind of scale this into my clinical practice, and you will see in the next slides what we have achieved. So the program was never designed for research. It's just to see if it is feasible to roll out lifestyle medicine to some of my patients. Next slide. And as you know, there is a whole lot to give to patients in lifestyle medicine. Simply, there is no way for a regular clinical practice to deliver all of that. So I had to come up with my own creative way. And you know, Maria Sharapova, one time when she was doing a commercial for Canon, she said, make every shot a power shot. I know Mahima has her own version of this, but this worked for me. Next slide. So what I tried to do was make every encounter a power encounter. Basically, I try to know everything I can about the patient one day before the visit, put the important parameters into my brain, the duration of diabetes, the medication burden, the complication, the age of the patient, time of onset of diabetes, as much as I can, so that in that 10 to 15 minutes of extra time I'm going to deliver to the patient, I use that as a power encounter, but at the same time, it is an empowering encounter. Mahima mentioned that earlier, we have to empower our patients for this lifetime medicine to be successful. One very stark finding I have to mention here is I practiced medicine in an area where less than 10% of my patients were able to read and write. That was in Ethiopia. However, in the US, 95% of our patients read and write. That's a huge resource that we are not using. And these medical literatures, brochures, you know, dietary screeners, all of that are in English. And they are written at 4th level or 6th grade level. And actually, our patients are waiting for us to kind of to engage them, and they are ready and willing to help us. And I consider this a coaching versus expert approach. I sit next to my patient, same level, consider this a meeting of the equals. And after I give them the traditional endocrinology care, I ask them if they are ready or if they are willing. I have a different approach to help them address multiple concerns at the same time. And if they are willing, I open a package of information in front of them and explain it in 10 to 15 minutes. The usual refrain is, of course, I wish I had more time, because there's no way I can cover the 6 pillars of lifetime medicine. My strength here is diabetes with my full-time dietitian and certified diabetes educator, and maybe exercise a little bit. Next slide. So I did not have to invent any wheels. I used these brochures from ACLM. All of that is downloaded and printed and made into a folder. And that's the 10-minute discussion I have with my patient. Next slide. And from the 5 A's approach of behavior change plan, I assess, advise, agree, assist, and arrange this plan with my patients. Next slide. It's about nudging. My exam rooms are decorated with things like movies, water are the best and cheapest medicine for type 2 diabetes, a bunch of nuts or a bunch of medications. And my patients, I encourage them to ask me, and this is a good conversation starter. Next slide. So this is my first 45 patient cohort showing A1C drop of more than 3 points in 3 to 4 months interval time. We all like p-values. These are very significant. They lost 26 pounds on average, and their LDL dropped by 61 points, about 15 patients. Next slide. So if you are interested, the raw data is available. And the first column is the A1C at the encounter, and the next column is A1C, final A1C. As you can see, patients achieved multiple goals, not just A1C, weight loss in the red column, and lipid panel. And if I had the power to capture many things like blood pressure, quality of life, and the data is really, really huge. Right now, we have, next slide. We have seen these patients at least 3 visits in 1 year, and they maintained the changes they acquired in that 3 months period. And this is very exciting because, as you know, clinical practice gives you a yo-yo kind of result, but this is very durable change because it was addressing the root cause. The patients are changed and their behavior is changed. They are enlightened to eat better, they exercise. And this is what you see, 3% drop in A1C at the end of the year, 45-point drop in LDL at the end of the year, and 18 pounds of weight loss for 43 patients at the end. Next slide. Lessons learned. Again, our patients are frustrated as much as our providers and our systems. They are ready and looking for options, particularly a talk on disease reversal and remission lights them up. They are thankful and helping spread the word. Lifetime medicine for major impact is doable, especially in shared medical appointments. Resources are readily available. Robust data collection and analysis are a must in seeking certification and reimbursement schemes. Next slide. Concerns and challenges, of course, this is not a one-man sport. Its strength is in inherent multidisciplinary approach. So encourage all of your other providers to be part of the team, dietitians, chefs, mental health, social work, and all that. And the lingering concerns are the education gap, where the ACLM is trying to close that gap by retro-educating the current providers and, of course, educating the future providers by lifetime medicine residency curriculum, currently running in 300+ programs in the US. Next slide. So lifetime medicine is suitable for a group of different practice entities. Number one, self-insured entities should be encouraged because they are willing usually to carry the risk and receive the reward. They have a large customer base to share the risk and spread the risk and capture the savings of lifetime medicine. For self-pay services, for example, direct primary care and concierge medicine is prominent examples utilizing lifetime medicine. And third-party payers like Medicare and particularly Blue Cross Blue Shield are also joining some of these efforts especially in safety net hospitals and clinics. And those are, saving themselves from catastrophic costs from complicated diabetes. Again, shared medical appointments are really the way to go until CMS clears the environment for standardized reimbursement schemes. Next slide. And then I'd like to acknowledge my clinic staff and leaders in ConHealth, ACLM and ACLM Health Staff Councils. These are my workforce. Basically, everything we do in my clinic is all about nudging our patients the right way. They learn from our t-shirts, our caps and all that, and they take it home, they get excited, they celebrate in the waiting room and celebrate in the communities. Next slide. And I'd like to close it by saying this: when diet is wrong, medicine is of no use. When diet is correct, medicine is of no need. I'm actually willing to cure some people in this process. Next slide. I'm sorry, we probably are off time a little bit, but we're going to open it for questions and answers.